for patients with muscle-invasive bladder cancer, there are two main treatment options internationally. Cystectomy, surgical removal of the bladder, which is either followed by chemotherapy before surgery, or sometimes chemotherapy afterwards, or sometimes immunotherapy afterwards, or the combination of chemotherapy and radiation given concurrently in an attempt to spare the bladder. So we know that when chemotherapy is given prior to surgery for patients with bladder cancer, prior to surgical removal of the bladder, we know that a pathological complete response is achieved in about 30 to 40% of patients when you look in that surgical specimen. So the question has arisen, do we actually need to have patients have their bladder removed to achieve cure if the cancer is actually eradicated? The problem is that it's been difficult to know that the cancer has been eradicated until the bladder is removed, so it's a little bit of a catch-22. So this really raises the question, can we develop clinical response assessment criteria that identifies patients who don't have to have their bladders removed immediately after systemic therapy? Can we identify clinical biomarkers that identify patients who can safely defer immediate cystectomy and have their bladders remain intact? So HCRN 16257 phase 2 study enrolled patients with muscle-invasive bladder cancer. Patients received chemotherapy with gemcitabine and cisplatin, plus the immune checkpoint inhibitor nivolumab. That was given for 4 cycles, and then patients underwent clinical restaging. Clinical restaging was defined by cystoscopy, biopsies of the bladder, urine cytology, and MRI of the bladder. If all of those assessments were normal, then patients were considered to have a clinical complete response. And patients with a clinical complete response could either opt to have their bladders removed, which arguably is standard of care, or they could decide not to have their bladders removed and receive maintenance immunotherapy and be monitored after that. If there wasn't a clinical complete response, then patients were recommended to have a cystectomy. So really the goal was to establish whether or not, to establish the performance characteristics of clinical complete response in predicting long-term outcomes. So really in predicting 2-year metastases-free survival, the concept was, could we use these clinical assessments to identify patients who could safely defer immediate cystectomy? So we enrolled 76 patients. 33 patients had a clinical complete response, so the clinical complete response rate was 43%. And among those 33 patients, only 1 patient opted for immediate cystectomy, so the remainder, the 32, opted for no immediate cystectomy. And among the patients who didn't undergo immediate cystectomy, 9 patients had a local recurrence, ended up undergoing cystectomy subsequently. The long-term outcomes, though, show that if there is a clinical complete response, then the likelihood of being metastases-free at 2 years is incredibly high, and the likelihood of being metastases-free with an intact bladder is actually quite high as well, in the 70% range.